few years ago, NHS England introduced a set of vanguard programmes across the NHS that were designed to encourage greater integration of services across primary, secondary and social care. And the reason we wanted to introduce greater integration of care was that it should improve people's experience of care, particularly people who have long-term conditions, who might receive care over time in different health and social care settings, and for whom their health problems, their social care problems, might be being dealt with separately rather than holistically. So the idea was that integrated care would be better for patients. But the government also hoped that by better integrating care services, it might also reduce health and social care costs and people's utilisation of healthcare services. So, for example, by having an integrated care team, there might be early detection of problems, and that might help prevent emergency admissions to hospital. It might be that by having better discharge planning, we could prevent people having to go back to hospital as a readmission later on. So the government hoped that these integrated care schemes would both be better for patients, but would also help reduce costs and use of services. One of these vanguard programs was introduced in South Somerset, and they introduced two forms of integrated care. They introduced what was called a complex care team, and they also introduced an enhanced primary care model. And the idea of both of those was in line with what the government wanted: improve experience of patients and help reduce utilisation of health and social care services. So together with my co-authors, we were asked to investigate the second of those issues, whether these integrated care models helped reduce people's utilisation of health and social care over time. This was a bit challenging because neither model was introduced in a randomised fashion. So what happened was the complex care team model was set up and the enhanced primary care model was set up, and they enrolled patients progressively over time into one or other of those models. And those models themselves also evolved over time. And of course, it was challenging because we didn't know what would have happened to patients anyway in the absence of being enrolled in one or other of these two schemes. So what we tried to do was we tried to match patients who were enrolled in the two models to otherwise similar patients who were living in other parts of Somerset. Then we compared their use of healthcare services over time and looked at the difference in utilisation between those two groups of patients to see if there was any difference. So what happened? Well, we found that there was no strong evidence that there was a reduction in utilisation of health and social care services that was related to those two models of integrated care. So as a consequence of our analysis, the aspiration that integrated care can reduce utilisation of healthcare services wasn't borne out by the evidence of the models in South Somerset. Now, of course, that doesn't mean that they're not worthwhile. It just might mean they might still be worthwhile models because, of course, patients ought to be better off as a consequence of their health and social care workers working more closely together, and there being a more coordinated approach to the care packages people with long-term conditions require. But the hope that these models will reduce utilisation, at least in the time period that we looked at, was not borne out by the evidence. And in fact, that chimes with other studies that have been conducted on the same subject, both in the UK and elsewhere. So if we want to introduce integrated care packages for people with long-term conditions, it's probably better to argue for those in terms of the benefits that will accrue to patients themselves, rather than the hope and expectation that they are going to reduce health and social care costs.